It is my privilege to present the next award for the Neurosurgery Socioeconomic Paper of the Year. I'd like to invite Dr. Stephen Honeybul to present a topic, an issue that touches each and every one of us in the emergency situation, and he's going to present around the opinion regarding acceptable outcome following decompressive hemicraniectomy for ischemic stroke.
Mr. Chairman, Mr. President, ladies and gentlemen, most of you will be aware of the pathophysiology of malignant middle cerebral artery infarction and the role of decompressive craniectomy as a life-saving intervention. However, surgical intervention will not reverse the effects of what is by definition a very severe stroke, and the concern for many years has been that a decrease in mortality may come at the expense of an unacceptable level of neurocognitive disability. These concerns prompted investigators to conduct a number of trials comparing hemicraniectomy with standard medical care. The interpretation of the results of these trials was that surgical decompression reduced mortality and improved favourable outcome. However, this result was only achieved by including a modified Rankin score of 4 in the favourable outcome category. In patients over 60 years of age, these findings were even more striking. The conclusion that hemicraniectomy increased survival without severe disability must be interpreted with caution, because most survivors were dependent with severe neurocognitive disability. So the aim of this study was to canvass opinion amongst competent healthcare workers regarding issues of consent and outcome following malignant middle cerebral artery infarction. The study was in 2 parts. In the context of small educational seminars, participants were presented with the pathophysiology, the role of decompressive craniectomy, and outcome assessment following middle cerebral artery infarction. They are also shown what was defined as unfavourable and favourable outcome based on the modified Rankin score. They are asked their opinion regarding consent if they are unfortunate enough to find themselves in this position. They were also asked what level of disability they would deem to be acceptable based on the modified Rankin score. In the second part of the study, they were presented with the evidence from the randomized controlled trials, much as I've shown you earlier. They were shown a significant reduction in mortality in the hemicraniectomy arm in patients randomized to surgery. They are also shown the non-significant improvement in favourable functional outcome and the increase in dependency in those patients randomized to surgery. They are also shown the improvement in outcome that can be achieved by incorporating a modified Rankin score of 4 in the favourable functional outcome. They were then shown the results of a study in patients over 60 years of age. Now, in order to provide a balanced argument, participants were then provided with evidence supporting the inclusion of modified Rankin score in the favourable functional outcome. At this stage, I declared my bias in that for me personally, I feel that this outcome to be unacceptable. However, the disability paradox neatly encapsulates the finding that many patients with severe disability report good or excellent quality of life. Indeed, this has been shown in a study that I performed in patients who had survived with severe disability following decompressive craniectomy for severe traumatic brain injury. To my surprise, most patients, when asked about the outcome they achieved, would provide what's called retrospective consent. Now, it could be argued that these patients had lost neurocognitive function so that they should not fully appreciate the level of disability. However, to my mind, that is of questionable relevance. Just because you're disabled does not mean your life has any less worth. An alternative, a more realistic interpretation is that patients have adapted to their disability. So in the final part of the study, based on the evidence presented, based on the disability paradox, it was clearly explained, and my bias, participants were asked to reconsider their initial responses. And here you can see the responses before and after. And the results showed 2 main categories of response. patients were unwilling to accept severe disability, and a smaller proportion who accepted the disability paradox and would provide consent. Overall, most participants felt that a modified Rankin score of 4 was unacceptable. So in conclusion, Mr. Chairman, based on these findings, is the sun rising or is the sun setting on use of this procedure? My answer really is that I'm unsure. What I think we have demonstrated is the complexity of consent in these circumstances, because even after half an hour of discussion of the evidence available and the issues involved amongst competent individuals, over 10% still unsure. So as neurosurgeons, where does that leave us at 3 o'clock in the morning? Mr. Chairman, Mr. President, ladies and gentlemen, I consider it a great honour to receive this award and a privilege to present to you. Thank you for your attention.